Going to pinch the spinous process of C2, and you're going to stabilize there. So side bend the head, and you should feel C2 move almost immediately because you're taking up the slack in that left. So if I'm side bending right, taking up the slack in the left alar ligament. So stabilizing spinous process of C2, side bend, and almost immediately you feel kind of that firm, like you would expect a ligament test to feel, right? These are thought to be in order of least provocative to most provocative. Although the Aspinal and the transverse ligament test, those are kind of the same, just different ways of doing it. But the sharp Purser test is the one you'd start with. It's a relocation test. So you're gonna have them start in a position that would be provocative and then move them out of that position. So their symptoms should actually get better if it was positive. Set up stabilizing spinous process of C2. Gonna rotate the patient's head. You should feel movement within 20 to 30 degrees. So this one you get a little bit more motion before you feel C2 start to move, more laxity in the ligament going into rotation. And again, you're still testing that left side with that one. But basically you're gonna have the patient seated again. They're gonna flex their head forward slightly. So the thought process there is you're creating, if there's increased laxity in that ligament, C1 is gonna slide forward on C2. And with your stabilizing hand, you're going to block C2. So come around posteriorly. And then you're just stabilizing C2, and then you're pushing directly posterior and a little superiorly, trying to relocate C1 back on C2. Symptoms go away. Or a positive could also be there's excess mobility there. So you're asking the patient, like, how are their symptoms changing? But then you're also assessing for that infeel as well, and is there excessive motion there? You are stabilizing the head with one hand, and then your shoulder's gonna come over, and then essentially with the other hand, you're trying to push C1 up. So you're trying to translate it forward as you're stabilizing the occiput. So if there's laxity in the ligament there, you're gonna get an excessive anterior force. They may have increased symptoms, numbness, tingling in the arms, or increased pain. So you want to get on the posterior arches of C1. All right, so you're stabilizing the head, and then you're pushing with the mobilizing hand, you're pushing straight anterior. So there shouldn't be any movement with this. I mean, maybe a little bit, but if you're getting excessive movement there, would be a positive as well. So take your fingers and hook the posterior arches of C1. You're just lifting up. With this one, you can hold it for up to 15 seconds, but again, assessing for nausea, loss of consciousness, because again, now you may be starting to get some VBI because you're also stressing that vertebral artery. So you would check for nystagmus, any facial numbness as well with that one too. So it's just a different way of doing the same thing, but then you could hold that one longer. But that's after you've cleared. So sharp Purser's negative, Aspinal's negative. Now let's do this one, and then we could potentially hold it. And then if there's no excess movement, no symptom reproduction, then you're probably good to go. But keep in mind that a lot of times patients with instability, they're gonna be really guarded. So some of these tests might be negative initially, but then as you start working with them, you might notice that, okay, wow, that actually feels like there's a lot of movement there. So just keep that in mind. Another thing is maybe they have pain. You're suspecting a facet issue, and they have pain with active extension that reproduces their symptoms, pain with side bending and rotation. I might not even do the Quadrant test because I've already I might poke around and try to isolate what level and that kind of thing, but you might not even need to do the Quadrant test if you already have your positive. Upright. So let's say you're trying to assess the right side. You're going to, the first technique you would do is side bend his head maximally to the right side. Is that any change in your symptoms? That's negative. Then you'd bring him into extension. Any change in your symptoms with that? And then the last thing you would do is rotate away. And the thought there, right, because you would think it would be rotate towards to maximally compress. So the thought is you're bringing the facet down with side bending and extension, so you're locking it in, and then with the rotation away, you're kind of shearing the joint. And the other big thing with this is you're looking for reproduction of their radiating symptoms, so whether that's numbness, tingling, or pain. So Sperling's A, you're just side bending their head as far as it will go. And then if they don't have any increase or change in their symptoms there, then you would apply a compressive load, about 7 kilograms of force to be exact. Symptoms in the arm, not just, oh, that feels uncomfortable. Okay, but does it reproduce the same symptoms it brought you in today? E is a progression of that. So if that was negative and you wanted to go further, you're no longer using the CPR, but you're going to a more progressive test. You're going to side bend, extend, and then rotate towards. So you're, yep, because you're trying to compress the neuroforaminal space now. You're not trying to push the facets against each other yet. You're gonna do it in sitting though. You wanna grip under the base of the occiput, and then I kind of do a little squat, and then compress in, and then stand up. Does that change your symptoms at all? Better, worse, no change? In order to be positive, you would expect that to relieve their symptoms. Fingers take up some of the soft tissue slack, so just sort of grip on the side and pull up a little bit. But then you're still coming over top of it. And again, I would have her much lower down so I could be over top and use my body a little bit more. And then you could do that, really you can do that in any level of the spine to help identify what level of involvement potentially. It doesn't tell you what's causing pain, but it might help you narrow down what level is irritated. For the purposes of cervicogenic headache, though, you're going to be looking at C1, 2, 2, 3 are usually going to be the primary levels that could refer into the head.
So for the unilateral one, you're not on the spinous process. You're on.
You move lateral to the
both
articular
sides.
pillar over top of it. So for a PA glide, it's real simple. You just get on the spinous process. PA. So your force is posterior to anterior. So you're on C2, the spinous process, pushing posterior to anterior. So you can unhook them. When you're testing the cervical spine, you want it folded into thirds, okay? So I'm gonna leave it folded. Be careful when you're unhooking these, they rip very easily, and once there's a hole in here, they start losing air and then they're no longer useful. Put them in hook line, so can you bend your knees for me? Perfect. And then once they're comfortable, you wanna make sure that they're not moving, because if they start adjusting their legs or moving their hands, that's gonna affect your ability to get a good baseline. And you'll see what I mean by that in a second. The other thing is you wanna make sure that their head is in a neutral position, that their neck on their thoracic spine isn't in too much extension, and that their upper cervical isn't in too much extension either. So with him, I might put the cuff or the stabilizer cuff under the base of the occiput. So you want to make sure that's under the base of the occiput. You want to make sure your patient's relaxed. You'll let them know that you're going to blow this up. You're going to put some air so they may feel a little pressure under the back of their neck. Because what you want to do is you want to get this gauge set to 20. And you want it to stay at that 20. So if they're moving, that needle's going to be moving up and down. But when I tell you to, you're going to nod your chin as if you're saying yes. But you just want to move your upper neck. You're not pushing into the cuff and you're not lifting your neck up off. You're just nodding a little bit. It goes up. What I want you to do is flex it up just to the top of that red, to the next tick mark there. Good. And then hold. So you'd have them hold that position so they go up to 22 millimeters of mercury, and they hold for a count of 10. But it's important that they're not compensating with their SCM. So my fingers are here palpating to make sure the test is done. They can't even go up 2 millimeters of mercury without compensating. So let's say they can go to 22 millimeters of mercury and hold for 10 seconds. Then the next step would be is can they go to 24? So then you would try to go up to the next tick mark. If they can do that and they can hold for 10 without compensating, then you could go up to the next tick mark. But typically you want to see that they can get up to at least 28 or 30. 30 is normal, but at that point you may start getting some SCM compensation that wouldn't necessarily be considered abnormal. So now he's 3 feet away. Based on this target, if he's 7 centimeters away from the middle of the target, if he's 7 centimeters or over, that's considered abnormal. So this second outer line here, because I've used this before and I've measured it, so if he's within that, that's considered normal. Really anyone with neck pain, you could look at it, but certainly if they're having cervicogenic dizziness, maybe if you notice that when they're moving their neck, they're getting all sorts of weird, they can't just turn their neck straight. So that, again, could be a joint mobility issue, but maybe you've assessed mobility and mobility's fine, they just can't coordinate the movement. That could kind of cue you that maybe there might be some issues with their position sense. They don't know where their neck is in space, or they don't know what those vertebrae are doing. They can't coordinate that movement. So you might start here. So if this isn't functioning well, if this system isn't working well, then it's going to be really hard to progress and get other movements coordinated if they don't have their basic proprioceptive capability in the upper cervical spine. So,
Josh, close your eyes and then look up toward the ceiling and then come back. One thing you can watch for also is if you see any kind of big deflections, because sometimes someone will raise their head up and they'll do like this. Maybe not quite that far, but you'll see the laser just shoot out. And you're like, oh, well, that's interesting. So just things to note during the exam. Same thing with turning. They might turn, but then also extend at the same time. So that can tell you something about their position sense or direction. Okay. So for an intervention standpoint, which may be on your practical, you could use this as an intervention with simple rotation and come back to center, or looking up or looking down and coming back to center. But we don't live our life just doing that, right? We live our life in many directions, diagonals. If you want to work on more coordination, say you saw that it was an issue just kind of keeping the line straight, maybe you have something they trace out. So you can get really creative with how you incorporate interventions. It's not just using the target for an intervention. But maybe I might ask you to match that more towards what is their phase 3 and how can you then kind of progress this, what's a good phase 2 intervention to link this to their phase 3. Does that make sense?
and there's different components of proprioception too. The test that I showed you is that basic level 1, do they know where their head is in space? Once they can do that, then maybe you notice their head-eye coordination isn't good, so then you start addressing that so that you can do the interventions. You can get really creative with the laser, but it depends on what is the impairment you're trying to address. Chin, so they're gonna flex their chin as far as they can, and then you're gonna have them lift up about an inch off the table. So can you lift up? I use my finger, don't push past that. You wanna hold about an inch up, hold there. So what you're looking for is how long can they maintain that off the table without coming out of their chin tuck. So as soon as they come out of the chin, you can relax. As soon as they come out of the chin tuck, you stop the test at that point. So you wanna watch, it sounds kind of funny, but look at this, you'll see skin folds. As soon as those go away, or as soon as you see that chin extend, that means they've come out of that neck flexion. The other thing you want to look for is if the head's starting to come back down towards the table, you would stop the test at that point too. It's important that they're only an inch off, because if they move very much further past that, then the gravity is actually helping them. So if they're really flexed far forward, that's no longer really assessing the deep neck flexors. Is somewhere around 38 seconds based on one study in the clinical practice guidelines. Even in patients with neck pain, they were generally able to hold up to about 24 seconds. So maybe a good cutoff would be is anything under 30 seconds might be impaired.